I put together a few objectives so that we have something to think about as I go through the talk. And I'm actually going, when I come to each kind of pain, I'm going to discuss how commonly it occurs. We just did our own internal survey here, and now we'll see what the rest of the data shows. We'll recognize the basic types of pain that are found in multiple sclerosis. And then we'll talk about the syndromes, or how they look and how you experience them clinically. Treatment will come in the next part of the talk. So it is common. We just saw that, and it truly is common. More than 50%. There's a large range. When I looked at studies, it was reported between 26 and 86% of people had pain in MS. And there are some factors, or what we call risk factors, that might put somebody more prone to having pain than other people. That would be older age. I mean, anything older than 2, I suppose. Older age, longer duration of disease. And so MS, it's really when you are diagnosed with this disorder, it's really a lifetime disorder. It's not something that goes away naturally. We manage it. We provide medications for you to treat this disorder. And so pain is associated as you progress through the disease. It seems to be more prevalent in the non-relapsing forms of MS once it gets to be more chronic, and that would more or less fit with the longer disease course as well. And those who have greater disability seem to experience more pain. Now, of course, that doesn't hold true all the time. It doesn't mean that if you're early on in your course and you're still functioning and doing all the activities you would like to do, doesn't mean that I'm saying your pain is not real. It just seems to accumulate more and occur more often in those groups. So there are, some articles talk about more than 5, but there really are 5 basic types of pain that we see in MS. And you may have not heard of these labels. Probably you heard of number 1, which is neuropathic type pain. And we'll be going through each one of these in detail. So there's neuropathic pain, what we call nociceptive type of pain, and then somatoform or emotional type of pain. That one's a little bit challenging to diagnose. Something called idiopathic, we really don't know the cause for it. And then mixed pain. Some people have 2 kinds of pain together. So let's first look at neuropathic pain. Neuropathic pain is the type of pain that comes directly from an illness. And in multiple sclerosis, it's going to come from your sensory system. And I have this diagram with this picture up here. You can see the brain, you can recognize that. And then there's a big nerve, that blue area there. That's the trigeminal nerve. And some people may have experienced something called trigeminal neuralgia, a very painful, sharp, shooting, shocking kinds of pain. And so there's a dysfunction in that part of the sensory system. So that's what neuropathic pain is, directly from malfunctioning of that sensory system. On the other hand, nociceptive pain is more due to really a mechanical problem, in the sense that sensory fibers at the end of them have endings that look like sprouts. You can see the picture up there. And if you bump your toe or stub your finger or slam it in your drawer like I did this morning at home, then you irritate those kinds of nerve endings, and those nerve endings are called nociceptors. And that's why this is called nociceptive pain. So it's the type of pain you feel when you burn yourself, twist your ankle, stub your toe. It can be dull, it can be sharp, and it can be all kinds of, has a large range. It can be mild and it can be severe. So can you appreciate this picture, what we're looking in terms of these nerve endings here? This is skin layers over here, and this is what we call subcutaneous tissue beneath the level of the skin, and these nociceptors go into the skin. Nociceptive pain can be brief and short-lasting, so it can be temporary, or it can be long-lasting and chronic. This is the type of pain category that occurs in diseases such as cancer or arthritis, because those nociceptors get activated. And at least fortunately for this type of pain, it typically or usually responds well to pain medications. And Dr. Green will be talking about pain medications. And in that category we have, when we talk about pain medications, this might be something, stronger than your typical anti-inflammatories, which are what we call NSAIDs, so ibuprofen, naproxen, those are anti-inflammatories, and 2 other medications that we use for pain. But the general message here is that it can be short-lasting, it can be long-lasting, and it does respond. Let's move on to what we call somatoform pain. As I mentioned, it's difficult to understand and even more difficult to define what this pain is because so much feeds into it, and then it seems to sometimes get larger than it actually is. And the things that feed into it is one's own personal beliefs, memories, fears, even about pain itself, and it seems to escalate it above the proportion of pain that we would expect for that particular disorder. And I say we should look at it from an outside-in approach or an inside-out approach. So sometimes from the outside in, you may have emotional conflict, or maybe there's stress in your life at home or from work or a job. There's many sources of stress in our life these days, or some psychological problem. We're not machines, we're humans. People have depression, people have anxiety, and those are common disorders in MS. And so some of that emotional conflict can, what we call, elevate or exacerbate, if you like that term, the amount of pain that somebody has. And yet, if you then have that pain, one can get despondent about it or depressed about the pain. So it becomes a cycle that's hard to break. And so we look at this as a combination, a complex combination of events and factors, even that stress that I mentioned, that lead to that production of pain. And that actual situation leads to a change in the nervous system itself. It's not something that we can clearly define, such as in the neuropathic pain, where I can point out a spot or a lesion along a nerve fiber and say, okay, I know the problem is coming from there. But there's something about the way the nervous system functions, the way it operates in that scenario, that's not normal. So what does it result in? What kind of pain would somebody feel from this? Well, they actually would feel physical pain in a body limb or a body part, and can be present in any part of the body. Typical syndromes that we find with somatoform pain are headache, muscle pain, backaches, stomach pains. You may be familiar with some of this. And if those psychological and emotional aspects aren't addressed, that pain may continue or go from temporary to chronic. So just because we can't on an MRI locate the source of your pain, it doesn't mean that it should be neglected or overlooked or have somebody tell you, oh, that pain is not real. Because you're feeling it, that pain is real. But if we understand it, then we can target it. It's helpful if we can identify a particular onset or an event that occurs with it, and that helps us to manage the pain. So if it occurred, for example, when you lost your very dear, pet at home or a dog, or you had to put down a dog, and that's when your pain started, or some particular stress factor, then we can help you and at least guide you towards somebody who will be able to help you in that regard and deal with that grief, for example. And the benefit on this kind of pain is actually the prognosis, or looking forward into the future, can be quite good. If you deal with the symptoms, if you deal with the cause of it, then it doesn't mean you have to live with this kind of pain long term. So that's very promising. All right, now we'll move on to idiopathic pain. Again, this is one that's a little bit poorly understood. And in this category falls those disorders such as idiopathic facial pain. I'll start at the bottom there. And some people have pain that's not trigeminal neuralgia, but they may have dull pain or pain that just doesn't come in those waves of shocks, or pain that doesn't have all the features of trigeminal neuralgia. And so then we call it idiopathic. There's interstitial cystitis. Maybe some folks here are affected by that. It's a bladder disorder, and it can be quite uncomfortable. IBS stands for irritable bowel syndrome. It seems that such a large portion of the population has that now, where you have this alternating diarrhea and constipation. That's one of those types of syndromes. And then fibromyalgia. Fibromyalgia is really a tough disorder in the sense that it falls mainly on the rheumatologic world, but it's kind of a diffuse pain that's hard to capture and hard to treat. It does have criteria for it, so if you feel that you have that disorder, it can be treated. But we don't really understand it very well. And what is mixed pain? So, for example, in MS, you can have different pains that are hard to distinguish from one another. And so if you have spasms, you know, in the office, I'll often ask my patients, how are your legs? Have you had any spasms? And we'll range your limbs in physical therapy. The therapist will do activities with you and exercises to loosen up your muscles. And so spasms seem similar to spasticity, but they're actually two different types of pain. So now let's look at each one of these categories and talk about some of the syndromes that we see with each one. So under neuropathic pain, we have ongoing extremity pain, we have trigeminal neuralgia, we already touched on that a little bit, and Lhermitte's. Many of you may have had a Lhermitte's along the way. So Lhermitte's, when you've brought your chin to your chest, and you don't really have to raise your hand on this one, but if you bring your chin to your chest and you feel some shocks, or if you've had that in the past, go down your back, or shocks into the legs or arms, that's Lhermitte's. And I will talk about it and define it for you a little bit. So let's look at ongoing extremity pain. And so about 12 to 28% across one's life, this occurs. It's constant, it's often burning, and this is one that affects the legs and the feet. It certainly is more common in progressive MS and associated with disability. So let's take a look at this picture here of the spinal cord. Ongoing extremity pain is associated with spinal cord plaques. Now what you see on this picture are not plaques, but these are different pathways in the spinal cord. And so extremity pain is often bilateral, and the plaques are often bilateral. So the central nervous system is made up of the brain and the spinal cord. So the brain has, we now know because somebody counted them, has 86 billion neurons. And each one of those neurons has a long fiber that goes down through the brain and then down into the spinal cord and then hooks up with other nerves that go to the arms and the legs. So the spinal cord is a big, long pathway, a big, long kind of messaging route from the brain with messages going to the arms and the leg. And when you have plaques or MS lesions in your spinal cord that are on both sides, it often contributes to this extremity pain. And the reason that's so is it affects pain and temperature pathways. This is a little bit of neuroanatomy, but I'm a big proponent for education, so we'll go there. And there are pathways in the spinal cord that carry messages for pain and temperature. That's how we feel it. You touch something, it goes up a nerve, goes into the spinal cord, goes up to the brain for processing. So that's how you feel pain. So this is not a peripheral nerve problem. It's not a problem of the nerves in the arms and the legs per se. It's a problem in the spinal cord, because MS is a central nervous system disease. So where do these pathways live? So you can see here that there are different areas carved out here. This is what we call the posterior or dorsal columns. And more towards the front, you have the spinal thalamic tract that carries pain and temperature. And so these are the factors that increase that risk of extremity pain. Because the spinal cord is long, there's more opportunity to have plaques along that length. That just makes sense. And if we go back to that picture, you can see that this pathway here is close to the edge of the spinal cord. And so what is close to the edge of the spinal cord? The cerebrospinal fluid. And so that's where this pain occurs, because there's more opportunity for you to have those demyelinating plaques. This is a central nervous system problem. It relates to the immune function that's going on within the brain that's carried into the CSF. And so if you're near the cerebrospinal fluid, more likely to have a plaque in that area. Another reason why people have limb pain comes from the brain. And if you recall, there are ventricles in the brain, and some people have plaques near those ventricles. Well, deep in the brain is a structure called the thalamus, and that's like the grand central station of the brain. When I used to live in New York and I wanted to travel, say, to Connecticut or something, you go down to Grand Central Station, you look on the board and you pick up the gate, you go to the gate that has the trains to Connecticut. So there's a lot of coming and going in that thalamus, just like a lot of coming and going in a big area. And so the fibers and that thalamus, it's also considered to be a baby brain. And in that thalamus, there are separate portions that are designated for carrying pain fibers. And because all of that are in areas that tend to get demyelinated by multiple sclerosis plaques, it can cause this extremity pain. So it's not imagined pain. There are real anatomical reasons why plaques and MS lesions in the spinal cord and in the brain cause this type of pain. That's the main message. So now we'll move on to trigeminal neuralgia. And I saw some people in the audience have this kind of pain. It's attacks of electric shock-like pain. It occurs in the face in a distribution of that cranial nerve 5, so either at the forehead or the cheek or the chin. And this occurs, according to the data, in 2 to 5% of people with MS. Personally, I've seen it more frequently than that. But MS itself poses one at a 20 times increased risk of having trigeminal neuralgia above the regular population. And it's due, again, to demyelination in that part of the brain. It's called the brainstem, where cranial 5 comes out. And we'll see that in a moment. There are other people unrelated to MS, or even if you have MS, who also get trigeminal neuralgia. And we call that classic trigeminal neuralgia. That's when there's a blood vessel just touching or pulsating against that cranial nerve 5, and it can irritate it and cause pain. So here we have a picture of the brain. And if you can see here, there's a white area. That would be a typical MS plaque. And if you can see this gray line coming out, this is the pons here, and where that gray line comes out, that's the trigeminal nerve, that cranial nerve 5. So if you have a lesion in the pons that's right near to that cranial nerve 5, that can cause trigeminal neuralgia. So this is a photograph of Dr. Lermite, and who described multiple sclerosis and the sensation of electric discharges. So what is Lermite's? It's short-lasting, shock-like again sensation that occurs when you move your neck up and down. It usually goes down the back, or you can feel it into your arms and legs, and this occurs in 15% of people with MS, although again, I must say I've seen it more commonly than that. And what happens, there's demyelinating plaques in the dorsal part of that spinal cord. If you go back to that picture you had, dorsal means back, more towards the back or posterior. And I often give the example when somebody has a demyelinating plaque, the insulation or the myelin sheath around a nerve fiber is being attacked. If the attack is severe, the fiber is also attacked as well. But if you imagine that analogy where the insulation is being attacked, then you just have exposed nerve fibers. And because there are so many of these fibers traveling down the spinal cord, if you have one fiber just adjacent to the other, which you do, so it's fiber, 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 and they've been stripped of their insulation, and then you bend your head like this, it's almost like a cross reactivity or a cross or a short circuit, and that electric shock by virtue of the mechanical pulling and the transmission from kind of stripped nerve to stripped nerve that causes that very shock-like pain. So that's the explanation for it. Let's move on to nociceptive pain syndromes. And many of you are, I'm sure, familiar with optic neuritis, but also in this category are musculoskeletal pains and back pain, headache disorders such as migraine and tension-type headache, and even treatment-induced pain. So optic neuritis, it's actually the presenting symptom of MS in 20% of people. It's usually accompanied by pain, and sometimes it just starts with the pain, and there's inflammation of that optic nerve. And so you're having demyelination along the optic nerve, and the optic nerve exits the posterior globe of the eye, and then it travels in what we call the orbit, and there's a little flexibility there because when you rotate your eyes, the optic nerve has to kind of move with it. And so if you again have demyelination in that nerve and you move your eye, that nerve is irritated and it's going to cause pain. It activates the nociceptors in that nerve, the pain fibers or the pain endings. What about musculoskeletal back pain? Very common. In MS, the numbers are a little bit over 15%, but there's lots of predisposing factors to back pain. You can have muscle weakness, as we know, spasticity again, and just reduced mobility, positioning. If you're relying on a wheelchair or during transfers, some of these can be difficult, and just the reduced mobility can give you some muscle pain. Again, it's nociceptive, irritates those endings. And what happens and what are the consequences of this? And so when you have uneven weight distribution, if you don't have correct positioning in your chair, or if it's old, or if you have an old cushion or something to that kind of scenario, it puts stress on your joints and on the ligaments that hold the bones together there. And so, for example, if you have uneven weight and stress on your joints and you're not moving much, then the next step is osteoporosis. You can also have reduced elasticity of the tendons and the ligaments. So all of this function, goes into play in functioning, and you're being able to walk as well as you would like to and not fatigue out and not have pain or back pain while you're walking. And this is why we're such strong advocates of physical therapy to help you with this. And then it can also lead to joint stiffness. So a little bit different from the regular wear and tear of arthritis. There are risk factors for having this kind of pain. And some of these I'm sure you're familiar with. Really, virtually all of the medications have some side effects. There's one type that causes flu-like symptoms. Injections can cause injection site reactions. So if you're injecting, and now we know about nociceptive pain, and we know that there are these little sprouty nerve fiber endings, it's no wonder that you feel some pain when you inject. You can have GI pain with some of the medications. It disrupts your GI system. Some of the medications, not for everybody, but it puts a few percentage of people at risk for neuropathy. Flushing can be, for some people flushing is just kind of a pinkness to the skin, but for other people it's annoying and they feel, heat and warmth. Infusion reactions, and so on and so forth. And now we'll talk about mixed pain. So we mentioned that if you have spasms and spasticity, this is really two different types of pain, but you're feeling each. And they're hard to distinguish because they're similar. So what are tonic spasms? This occurs in a little bit more than 10% of people with MS. Again, more common in the types that are not relapsing MS, so in primary progressive and in secondary phases of MS. Again, associated with age, duration of MS, the amount of disability, and this can be on one side or both sides. Tonic spasms are involuntary, so it's not something you're doing yourself or you control. It's just the muscles contract. They're not as brief as the shocks of trigeminal neuralgia. They can last up to 2 minutes and many times a day. So you can imagine this is highly uncomfortable. They can last for weeks to months and be triggered by certain things. And so even though they occur, they're not voluntary, certain things that you do or certain actions can bring them on. So even just touching the body part or moving, or again, the emotions play into it like we talked about before. And once a contraction occurs or a spasm occurs in one part, then adjacent parts seem to pick up that message and they start spasming too. And the science behind this is that the motor pathways, so we talked about sensory pathways, but the brain and the spinal cord also have pathways for movement. We call these motor pathways. And there's a particular tract, it's called the corticospinal tract, and we saw that on our diagram too. And that sends the message from the brain down through what we call the capsule, down into the brainstem, we call that part the cerebral peduncle, down further into the brainstem where we call the medulla, and then into the spinal cord. So it's like if you're traveling from New York to St. Louis, you pass through all these different towns and places. What happens when you have a spasm? Well, when the muscle spasms, the blood vessels that run through that muscle or near to that muscle, they get compressed. And that activates those little sprouty things on the muscle cells. And that causes muscle pain. At the end of the spasm, the muscles calm down, the blood flow returns, and your pain goes away or decreases. That's different from spasticity. Spasticity, we can see here, is really common. More than 50% of people. It's damage, like we saw that neuropathic pain is damage in the sensory pathway. Well, spasticity pain is damage on that cortical spinal tract that we just outlined before. And this is a prolonged contraction rather than just a spasm. It's different from those tonic spasms. The way the spinal cord works there are what we call reflex arcs that send messages to and out of the spinal cord. And when it operates normally, just one muscle group is supposed to contract at a time. So like if you make a fist and you bend your arm, you have contraction of your bicep. But in MS, you lose this control from high up. And so everything is contracting, and it almost feels like to you, if, like you went to the gym and you worked every muscle and they got strained and they're, burning and aching because you overworked those muscles. And that's what your muscles are doing. And so the spasticity is activating receptors on overworked muscle, and that's what's causing the pain. And when these muscles are contracted, when you try to lengthen that muscle out, it also excites those receptors. So you kind of get it from both sides. Well, we've come to our summary now, and there's probably no other disorder that results in so many types of pain. I hope that this presentation has increased your understanding of the basic types of pain, and by doing so, helps you to better manage your pain. And I put ... should you experience it. So thank you for your attention.